So sometimes, though, patients come in and they have signs of meningitis, and they get a tap and they have white blood cells, but they actually just have a virus. This is really common in the fall and winter months when we see outbreaks of enterovirus throughout the United States. So in Boston, a doctor named Lisa Nigrovich put together a set of rules that are very effective at allowing us to rule out meningitis immediately when we first evaluate the child. This is fantastic because it means in most children, we can send them home from the emergency room with a bad headache, knowing it's just viral disease and it will get better, rather than needing to admit these patients to the wards and give them antibiotics. Let me specify, this rule does not apply to your neonates. To those kids under 8 weeks of age, we should not be using these rules. These rules are really for older children. So what are they? If all of these are true, you do not have bacterial meningitis. 1, you should not have seized. No seizures allowed. 2, your CSF protein should be less than 80. 3, your CSF absolute neutrophil count should be less than 1,000. Your CSF absolute neutrophil count is calculated just like your serum neutrophil count. It's the number of cells times the percentage of bands plus segs. Your total blood neutrophil count should be less than 10,000. And your gram stain should be negative. If all of these things are true, you may presume that this patient has viral meningitis and not bacterial meningitis, and the prognosis is outstanding without any treatment. There's one other thing or a few other things that we want to consider. The first is Lyme disease. There are some areas in the United States, like the Northeast and the East Coast really, that are more endemic to Lyme disease. In patients with Lyme disease, that absolutely presents with headache, and those patients absolutely get meningitis, particularly in the early stages of disease. If a patient has had 7 days of headache, or their 7th cranial nerve is abnormal, or they have more than 70% monos in their spinal fluid, that's a sign this is probably Lyme disease, not another cause, and you should treat them accordingly. If the enterovirus PCR is positive, especially in the fall and winter months, you really don't need to worry about bacterial disease and you can stop the antibiotics. Keep in mind, while enterovirus is a benign illness in most people, in small babies it can be they can be very sick and they may even die. We've seen that before. Keep in mind for patients with tuberculosis that you may need to do extra testing. I've seen a few cases of TB meningitis, and those kids can be particularly sick and very challenging to treat. If you suspect TB meningitis, we'll usually get an acid-fast bacilli stain on the CSF, and we may test them with an interferon gold test. In patients who might have HSV, in their early childhood, for example, or in older children with oral lesions, we will suspect they might have encephalitis. This is not just a pure meningitis. The infants are usually sick. They might have seizures and hypothermia and irritability, and older patients will generally manifest with full-fledged encephalitis. They may have a meningitis component, but think about HSV in patients with encephalitis. It may be you need more testing in immunocompromised children, or in patients where there's signs of encephalitis or signs of focal disease. These are exceptions that we have to consider when we might have to ramp up our testing. If you suspect bacterial disease, you want to admit infants who you believe might have bacterial meningitis. If you've proven that it's not bacterial meningitis, you can presume it's viral and send them home. We're going to approach this differently depending on the age of the child. And we discussed this a little bit in our febrile infant talk as well. In neonates, we're going to treat with ampicillin and either gentamicin or cefotaxime, and we're going to sometimes give them acyclovir if we're concerned about HSV meningitis. We'll do a rule-out sepsis for 24 to 36 hours, and once they're negative, they can probably go home. We'll presume it's viral. If a patient has evidence of meningitis on exam and has CSF pleocytosis between 4 and 8 weeks of age, we're going to start ampicillin and ceftriaxone. And we're going to rule that patient out by watching them until the CSF culture is negative. In older children, we'll often use vancomycin and ceftriaxone. The reason for this is strep pneumoniae becomes slightly more common. And because these children are so remarkably sick, we have to make sure we're treating every possible bacteria. And so those few streptococcus that are resistant to ampicillin will be treated effectively with vancomycin. Another trick about treating patients with meningitis is they may have SIADH. So they may develop hyponatremia. And we need to be careful with their hydration status. Additionally, there is some evidence that patients with Neisseria meningitis may respond to steroids. That evidence hasn't held out for other infections like strep pneumo, and so it's somewhat controversial whether to give steroids or not. That's something you should discuss with your infectious diseases team. Generally, the way we're going to treat bacterial meningitis in children is we're going to provide IV antibiotics until the lumbar puncture repeat culture is negative. This usually requires multiple weeks of antibiotics. For strep pneumoniae, we'll treat for 2 weeks. For Neisseria meningitis, we can treat for 1 week. And for Hib, we'd treat for 10 days. So it varies depending on the nature of the illness. Little infants often get 2 to 3 weeks of therapy. After therapy is done, it's indicated to check for hearing in infants. This is because deafness is strongly associated with infectious meningitis. Early intervention is indicated after treatment because even in children who are effectively treated, they may result in some learning deficits or cerebral palsy or a long-term problem. And that may not be noted immediately after therapy. It may show up over time. So early intervention is key. We have to get them plugged in and followed and intervened with early so they can have a better outcome. These patients in general with bacterial meningitis have a variable prognosis, from a normal outcome to severe MR or possibly even death in 5 to 10%. Remember, sensorineural hearing loss is common, happens in almost a third of patients. Likewise, another potential side effect is hydrocephalus. These patients may have a problem with drainage of the CSF out of their ventricular collecting system, and they may end up needing a VP shunt. Patients may develop vascular infarcts of the brain and have deficits as a result. For example, they may present with hemiparesis afterwards. This isn't that uncommon. So, in summary, we're going to treat this disease effectively and quickly and as rapidly as we can and as thorough as we can, but then we need long-term to be watching out for their development, their hearing, and they need to get the intervention that will help them develop and grow. So that's my summary of meningitis in children. Thanks for your time.